Patayin mo na yung makina, yeah. Nang uminit pa, maakit ka na. Sige magalit ka. Haba ng passenger seat, empty road, four-seater, para meron tayong space sa likod. Ating sulipin ang hamog, magsisilbi na taklo. Pangiling di malagot, na masilip sa loob. Sa loob ng aking BMW sedan, fucking sa aking BMW sedan. Ang hiling di malagot, na masilip sa loob. Sa loob ng aking BMW sedan.
Good morning, Doc Kim.
Oh, hey! I didn't see you there. Good morning. How may I help you?
I am just lost in this very prestigious school. Can you please give me a background about your friends here?
Sure, why not? But before I start, let me tell you a secret.
Oh, what? What?
I have superpowers.
Really? Oh, what superpowers?
Don't shout, don't tell anyone. Every time that I touch someone, I can see their future 10 years from now. Do you want sample? Come, let me show you.
Really?
Here's the first classroom.
Let's see. Show me, show me.
Uy, Tim!
Oh, hey!
When doing the physical exam, remember to prepare the patient properly for examination. Introduce yourself, assure privacy, and explain the procedures in a way that the patient will be able to understand. For the general survey, observe the patient immediately once he comes in. Observe for the general state of health of the patient. Check for his ambulatory status, his posture, as well as his mental state, sensorium, or level of activity. Check for any signs of cardiac or respiratory distress. Observe for his nutritional status and also his hydration state. And take note if the patient is ill-looking or not. The temperature can be obtained via the axillary, tympanic, forehead, oral, or rectal routes. However, the oral and the rectal routes are no longer recommended. If the temperature will be taken from the axilla, you can use a digital thermometer to get the temperature. If on the forehead, use a handheld scanner. If in the ear, use a tympanic or ear thermometer. To get the pulse rate, place the pads of your index and middle finger on the radial pulse of the patient and count the pulsations to get the pulse rate. Also, take note of the rhythm, if it is regular or irregular, and the volume, if it is full, weak, or thready. To get the respiratory rate, count the number of chest rises for 1 full minute. Take note of the patient's respiratory pattern. For the blood pressure, the BP cuff bladder should cover 2/3 of the upper arm length and about 80 to 100% of the mid-arm circumference. First, let's estimate the systolic blood pressure using the palpatory method. Palpate the brachial artery and then inflate the cuff rapidly until you can't feel the pulse, and then inflate it 20 to 30 millimeters mercury higher. Now deflate the cuff at 2 to 3 millimeters mercury per second until you can start to feel the pulse again. This is the palpable systolic pressure. In auscultatory blood pressure, so rapidly inflate the cuff 20 to 30 millimeters mercury above the palpable systolic blood pressure, and then you deflate the cuff at 2 to 3 millimeters mercury per second and listen for the correct cuff sounds. The first sound will be the systolic blood pressure and the last will be the diastolic blood pressure. So record your results.
Uy, Tim! Musta?
Oh, hey sis. Come on, man. Up here.
Now, let's proceed with the anthropometrics. So first, to get the weight of our patient, we use a calibrated weighing scale. Next, for the height, it is measured using a vertical board with an attached metric rule and horizontal headboard that can be in contact with the uppermost point on the head. The patient should stand in a flat surface, close together and the head positioned with the line of vision perpendicular to the body. The arms should hang freely by the sides, and the head, back, buttocks, and heels are in contact with the vertical board. Then we should record the measurements to the nearest 0.1 centimeter on the growth chart. We now check for the patient's skin. Compare the skin within other body parts. Watch out for skin lesions, abnormal pigmentations, rash, eruptions, scars, edema, or even color changes. We can also check for the skin turgor by slightly pinching the skin of the patient's volar aspect of the forearm or at the anterior abdominal wall. And in a normal and well-hydrated patient, the skin will go back immediately. However, if the skin tenting will last for more than 2 seconds, this would indicate severe dehydration. On the other hand, this test would become false positive in malnourished children due to the loss of subcutaneous fat.
Kamusta?
Uy. Oh, Mia, what's up?
Starting with the head, check the position, size, and shape while the patient is facing forward. Inspect the hair for its quantity, color, texture, surface characteristics, and strength. Palpate the scalp using the fingertips. Face should be assessed for symmetry, expression, unusual phases, deformities, lumps, and bumps. For the eyes, start with the external structures. Note for abnormalities like periorbital edema, drooping eyelids, scaliness, crustings of eyelashes, and hypertelorism. Check the conjunctiva for pallor, hyperemia, subconjunctival hemorrhages, and opacities. Check the sclera for any discoloration. Assess the visual acuity using the Snellen's or E-chart. Make sure that the distance between the chart and the patient is 20 feet and test one eye at a time. For the pupils, check for the size and reaction to light. Use a pen light to shine a light on your patient's eye and check for the pupillary reaction. In examining the extraocular muscles, use the 6 cardinal positions of gaze. The path may trace out the letter H. Ask the patient to follow the finger and observe for any abnormal movements. True cause cover test to check the tendency of the eye to misalign upon the interruption of vision. First, occlude the patient's right eye for 3 counts. Move the cover to the left eye, passing over to the bridge of the nose. As the cover moves, check the uncovered eye for any movement. Repeat the test on the other eye and do the procedure twice or thrice. Which is done with an ophthalmoscope. Hold it and adjust them. Open the light source and look at looking. An orange color red-orange leaf flicks. This may indicate abnormalities that need. For the physical examination of the nose, check for the following: the patency of each nostril, the presence of alar flaring, the presence of discharge, and the position of the septum. To better visualize the cavity, have the patient seated and tilt the patient's head up and lift the nose upward. Also check the sinus tenderness by pressing both eyebrows on both maxillary areas. For the physical examination of the mouth, check the lips for color, moisture, excoriations, and cleft. Check the gums for color, continuity, and bleeding. Then the tongue for size, moisture, color, and abnormal movement. Also check for the dentition, palate, posterior pharyngeal wall, and the tonsils. Finally, check the throat with the bright light and tongue pressure for better visualization of the throat's posterior structures. For the neck, check its size, shape, and range of motion by asking the patient to move his or her head forward, backward, and to the sides. Inspect and palpate the cervical lymph nodes, and it should feel discrete, easily movable, and non-tender. Inspect and palpate the thyroid gland laterally below the thyroid cartilage. Ask the patient to swallow upon palpation. For the ears, check its size, shape, and location. The position of the ear in relation to the rest of the head should also be noted. Palpate each auricle and pull it down gently. There should not be any pain. Palpate the posterior auricular and mastoid area and check for tenderness. To check for hearing problems, do the Weber and Renate test. Weber is done by striking the tuning fork and places it on the top of the patient's head, while Renate test is done by striking the tuning fork and places it on the mastoid bone behind each ear. Lastly, do the otoscopy. Pull the pinna upward and back. Insert the speculum into the ear canal in the corresponding direction. Handle the otoscope like holding a pen. Check the tympanic membrane for continuity, position, presence of cone of light, color, consistency, and mobility.
Hi, Tim!
Hey, classmate!
Inspect the precordium and look for any visible pulsations over various parts of the chest and in the epigastrium. Palpate the chest by placing the palms at the back and observe for equal and symmetrical movement of the thumbs moving away from the midline. To test for tactile fremitus, the ulnar surface of the hand or the palm is placed at the back, then ask the patient to say 99. Repeat this at the anterior chest. Directly percuss with one finger over the chest wall cavity. The left middle finger will serve as the pleximeter, and the right middle finger will serve as the plexor. Repeat this at the anterior chest wall. Use the diaphragm of the stethoscope to auscultate for high-pitched sounds. Characterize the individual heart sounds and variations with respiration. Now use the bell to detect low-pitched sounds. S3 sounds may be heard and can be normal in a young patient with tachycardia. Describe any murmurs according to their intensity, pitch, and timing.
Hi, Tim!
Oh, hey! Thanks for opening the door. Hello, classmate!
Now, let's proceed with the physical examination of the abdomen.
To facilitate the localization of abdominal PE findings, the abdomen can be divided into quadrants or into 9 parts as we can see here on the picture. First step is inspection. Take note of the size and shape of the abdomen, whether it is flat, scaphoid, full, globular, or protuberant. Check for prominent vessels, striae, pulsations, peristalsis, umbilical hernia, and paradoxical abdominal movements with breathing. Next is auscultation. Warm the diaphragm of the stethoscope with your palm, then place it lightly on the right lower quadrant or mid-abdomen to listen for bowel sounds and note the character and frequency. Bowel sounds are gurgling in nature, and they occur 5 to 34 times per minute. Auscultate for 1 to 2 minutes if bowel sounds are absent. High-pitched sounds may be associated with bowel obstruction and diarrhea, distant sounds with ascites and peritonitis, and if absent, it may point to ileus. Next is palpation. Ask the patient to lie supine with both lower extremities semi-flexed at the knees and hips while you stand on the right side of the patient. Before palpating, warm the hands and instruct the patient to inhale slowly and deeply to relax the abdomen. Ask the patient if he has abdominal pain and start palpating away from the site with maximal pain. To palpate, use the flat side of the fingers of the dominant hand. Palpate lightly to assess skin turgor and muscle tone and to detect any masses, then palpate deeply in the same areas. If the patient is ticklish, place your hand on top of the patient's hand, overlapping the fingers, then palpate. We can also palpate for the liver, which may be palpable 1 to 2 centimeters below the right costal margin. The edge should feel sharp and soft and should move easily. The next part will be shown by Kim.
To check for splenomegaly, the patient should be in supine and start palpating from the right lower quadrant to the left costal margin using the right hand as the patient inspires deeply because the spleen enlarges below the rib cage along the abdomen toward the right lower quadrant. The left hand may be used to lift the left rib cage and flank. And in patients with a large spleen, palpation should be gentle as heavy pressure may cause splenic rupture. Castell's method can detect mild splenomegaly by percussing the lowest intercostal space on the anterior axillary line with patient supine. Normally, resonance is noted. Proceeding to the percussion of the abdomen. This is useful in identifying the presence of ascites, especially when dullness is noted. When highly tympanitic, suspect colic, intestinal obstruction, or ileus. The patient should be in supine and percussion should begin peripherally. Dullness may be noted at first, but as percussion progresses centrally toward the area of the air-filled intestinal loops, it should emit a tympanitic sound. To test for shifting dullness, the abdomen is percussed from midline to the right flank until dullness is perceived. A mark is placed at the area where the dullness is noted. When the patient turns to one side or the other, the locations of tympany and dullness shift as the fluid moves into dependent areas. The patient is asked to lie on the right side for at least 30 seconds, and after the fluid has settled down, percuss again from the left towards the right flank. Note the transition where tympanism changes into dullness, and if fluid is present, the dullness will shift upward. To determine the liver span, percuss the chest along the right midclavicular line anteriorly with a pleximeter finger held parallel to the ribs along intercostal space using heavy percussion. Percuss downward until resonance shift to dullness, and mark this as the upper border of the liver. Next, percuss from the right lower quadrant moving upward along the right midclavicular line until the tympanitic tone turns to dullness, and mark this as the lower edge of the liver. The length from the upper to lower liver edge is the liver span, noted in centimeters. The costovertebral angle tenderness is done only in older children or adolescents. To elicit, have the patient sit up on the examining table. Strike the patient firmly on the costovertebral angle located between the 12th rib and transverse process of the upper lumbar vertebrae. Another technique is to place the palm of one hand over the costovertebral angle and use the heel of your closed fist to strike the dorsal aspect of the hand over the CVA. Compare the left and right side, and presence of tenderness indicates renal inflammation, often due to an infection.
Ano ba nakalimutan? Oh, hey brother! I didn't see you there.
Uy! Tim, nandiyan ka pala! Wait lang. Alcohol.
Come on, man. I miss you, brother. I miss you. Come on, brother. Come on.
Hi! So, ako yung doctor mo ngayon at tawagin mo na lang akong Doc Mike. Okay? So, saan ka mas nakakaintindi? English or Tagalog?
Tagalog na lang po, Doc.
Okay. So, kumusta ka naman ngayon?
Mabuti naman po. Stress lang po sa online class.
Online class. Kasi kailangan nyo talagang mag-adjust ngayon since pandemic at saka para sa safety nyo rin. Okay? So, bago tayo magsimula, may mga konting katanungan lang ako. Pwede nyo ba siyang sagutin?
Opo, Doc.
Okay, sige. Ano yung buong pangalan mo?
Micol Zerin Paz Lopez po, Doc.
Okay. So, anong petsa na ngayon?
February 12, 2022 po.
Okay. So, ano sa oras naman? At saka kung asan ka ngayon?
Around 3 p.m. po dito po sa Metro Co-op Clinic.
Okay. So, may mga bibigay akong tatlong salita, okay? Ang gusto ko lang gawin mo ay ulitin mo lang ito. Una, mangga, mesa, pera. Pwede mo ba siyang ulitin?
Mangga, mesa, pera.
Okay, galing. Pwede mo bang spell yung salitang karne?
K-A-R-N-E.
Mahusay. Pwede nyo ba siyang baybayin mo naman ito pero pabaliktad?
E-N-R-A-K.
Tama. So, eto. Alam mo ba kung anong tawag dito?
Relo po, Doc.
Ito naman. Anong tawag dito?
Tumbler po.
Saan to ginagamit?
Pang-inom po.
Galing. Tama. So ngayon naman, magbibigay ulit ako ng mga salita at gusto ko lang gawin mo ay ulitin ang mga ito. Okay? Nagprito ng 77 puto ang pumipitong puting pato. Pwede mo nang ulitin?
Nagprito ng 70 puting puto ang pumipitong puting pato.
Okay, good. Ngayon naman, bigyan mo ako ng thumbs up sa kanang kamay at thumbs down sa kaliwang kamay. Ngayon, bale sa loob ng 1 minuto, magbigay ka ng mga salitang nagsisimula sa letrang B. So, as many as you can na. Pero bawal yung mga pangalan ng mga tao or pangalan ng mga lugar at saka mga numero. Okay?
Okay po.
Sige, simulan na natin.
Bola, basket, belt, badminton, bag, baseball, bintana, baso, bugok.
Ha? Bugok? Saan mo nalaman yun, ha? Ikaw, ha? Okay, good. So, kanina, di ba, may binigay akong 3 salita. Kung naalala mo ba, pwede mo ba siyang ulitin ulit?
Manga, mesa, pera.
Okay, magaling. Sa school nyo ba, may mga subjects kayong math or algebra, ganun?
Meron po.
So, okay. So, magbibigay ako ng basic calculations lang at gusto ko lang gawin mo, sagutin mo lang ito, okay? Sige, simulan natin. 2 times 2.
4 po.
Times 2.
8.
Times 2.
16.
Times 2.
32.
Times 2.
64.
Times 2.
128.
Okay, sige. Galing. Okay, so ngayon naman, may tanong ako. Ano yung pagkakatulad ng isang tren at saka tricycle?
May gulong po, Dok.
Ay, wait lang. Gulong? Hindi. Aside from nun.
Parehas po silang sasakyan para sa transportasyon po.
Okay, magaling. Ngayon, ang huli kong tanong, okay? Bibigyan kita kasi ng isang sitwasyon, pero sagutin mo lang to, okay? Bale, kumbaga, nasa parke ka, tapos naglalakad ka, tapos may nakita kang wallet sa sahig. Anong gagawin mo?
Pupulutin ko po, tas titignan ko po kung may ID, para sasauli ko kung kanino may-ari. At kung wala naman po sa aking paligid, pupunta po ako sa police station para ibigay na lang, para sila na lang maghanap kung kanino po yun.
Okay, sige. Ngayon, okay, huli na talaga. May papadrawing ako sa'yo. I-drawing mo naman sa akin yung orasan, tapos kasama na yung mga numero at saka yung arrows. Okay? Bigyan kita ng sample, ha. Drawingan mo ako ng 2 o'clock. Okay.
Wait, I will check the other room first.
First, we will test the patient's olfactory nerve. Now, in my hand are 2 solutions of coffee and vanilla milk. I will first present the coffee to my patient. The patient has correctly identified the smell. Then I will let the patient smell vanilla. Next test for the patient's optic nerve is confrontational testing. This is to test the visual fields of our patient. The patient is asked to cover one eye and look at the face of the examiner, and when a finger is moving, to point out the moving finger when they see it.
The next test we'll be doing is a fundoscopy. The right eye is examined with the examiner on the right side of the patient with the ophthalmoscope on the examiner's right hand. The optic disc is sharply defined and often salmon color, which differs from the pale gray color of the disc in an infant. Light reflex.
Most gracious Virgin Mary, that never was it known that anyone who fled to your protection.
Here we observe the patient's pupillary light reflex. When a light is shined on the patient's eye, the pupil constricts.
Inspired by this
We will check both eyes
fly unto you,
to see if
Virgin of
the
Virgins
pupils
Mary.
constrict upon
To you do I come,
shining of the
I
light.
stand, sinful and sorrowful. O Mother of the Word incarnate.
To test for the cranial nerves 3, 4, and 6, we will check the position of the eyes on primary gaze and the size of the fissures. Ask the child to track objects and check for any limitation in extraocular movements. Next, we're going to test the patient's convergence. Ask the patient to follow a target while it goes near their eyes. We will be observing constriction of the pupils and convergence of the eyes. To test for the trigeminal nerve, we test sensation using cotton. We use it to touch areas from the vertex of the head and ask the patient where they felt the sensation, touching the face and also the mandible. We may also use a pinprick and ask the patient where they felt the sensation. We will also do the test on the opposite side of the face. Next, we're going to test the patient's corneal reflex. With the patient looking at the opposite side, apply a wisp of cotton into the cornea. When the patient spontaneously blinks, it means that there is an intact 5th and 7th nerve. Now we will be testing the patient's trigeminal nerve and muscles of mastication. We will ask the patient to chew some food and we will palpate the masseter and the jaw and observe for any deviation. Test natin yung taste mo. Pag naka-taste ka ng matamis, taas mo 1. Next, we're going to test the patient's sense of taste. We'll ask the patient to raise 1 finger if they taste salty and 2 fingers if they taste sweet. In my hand is a solution of salt and water and we will apply it to the patient's tongue. On the right side first, the patient has identified the correct taste. Now, I have switched to a solution of sugar. We will apply it on the patient's right side of the tongue. The patient has properly identified the taste. Now we will go back to the salty solution and put it on the opposite side. The patient has also correctly identified the taste. And lastly, we will apply this sweet solution into the opposite side. We will now be testing the patient's vestibulocochlear nerve using the Rin test. Place the vibrating fork behind the ear over the mastoid bone and just after the sound disappears, hold it beside the ear over the external auditory canal. Normally, air conduction is more efficient than bone conduction and thus will be heard longer than the bone conduction. Perform the test as well on the patient's other ear. Caloric reflex testing. Caloric testing can be used for gross assessment of the vestibular function. While the patient is in the supine position and the head is flexed at 30 degrees, ice water is injected over 30 seconds into the external auditory canal, one canal at a time. The patient will develop coarse nystagmus towards the ipsilateral ear with no eye deviation. We're now going to test the vestibulocochlear nerve using the Weber test. A vibrating tuning fork is placed on the vertex of the patient's head or over the forehead. A normal child appreciates sound at the middle or equally on both sides. To test the glossopharyngeal and vagus nerve, have the child say ah and stick the tongue out and observe the symmetry and movement of the uvula and soft palate. Touch the back of the pharynx with a tongue depressor and watch the elevation of the palate.
Hey, Tim! Okay, so the first test is to just walk to that green ball and you walk back, like normal. While the patient is walking, note for any abnormalities in gait, any asymmetry, tripping, clumsiness, or involuntary movement. Okay, next is you do the same thing, but then you walk on your heels like this. Heel walking allows us to assess the patency of the ankle dorsiflexors, so inability to do this may indicate corticospinal tract damage. Last is to walk on your tippy toes like this. Toe walking helps us see the strength of plantar flexors. Like the heel walk test, this allows us to assess for any distal leg weakness. The next is called the tandem gait test. So basically, you're just going to walk like you're walking on a string. Tell the patient to try walking in a straight line with the heels touching the toes in front of each other. The tandem gait test is generally a test for cerebellar and vestibular function as well as muscle coordination. Inability to do this may mean alcohol intoxication, weakness, vertigo, or cerebellar problems. So now I'm just going to compare your muscles if they're symmetric and if they're equal. To gain an overall assessment of muscle bulk and tone, simply inspect the symmetry of the muscles at rest. Compare their tone by gentle palpation from the arms, palms, thighs, and calves. Keep an eye out for any fasciculations, atrophy, or rigidity. Now I'm just going to see the tone of your muscles when I'm moving it. To test the tone at passive motion, move the extremities at major joints and note for any spasticity, involuntary movements, or abnormal resistance. Upper motor neuron lesions like cerebral palsy or lower motor neuron lesions that lead to atrophy may present with abnormalities when passive motion is elicited. Next, I'll be testing for your muscle strength, so just grab on my fingers like that and pull. Gently lang. Okay. And then do this and try to pull towards you. Grade the muscle strength from 0 to 5. So next I want you to touch your nose and then you touch my finger repeatedly. And then just follow my finger there. Tell the patient to do the finger to nose test. Move your finger from side to side to see if the patient can follow the movement. Inability to do this or dysmetria can indicate cerebellar lesions. So next, using the heel of one foot, you do this. Yeah, like that. Alternatively, dysmetria could also be assessed by letting the patient rub his heel against his shin from up to down. Next, I want you to tap on your thigh, and then, but fast. Lastly, look for dysdiadochokinesia by letting the patient rapidly supinate and pronate his hands. I will be assessing for your deep tendon reflexes, so you don't really have to do anything. Just relax your muscles and I will do the work. So yeah, relax. To check for C5, C6 patency, check for the biceps reflex by tapping on the biceps tendon and looking for forearm flexion. Next, I'll be doing the same thing but on your knees, okay? Yeah. Check also for patellar reflexes, which is a function of L2 to L4 by tapping on the tendon below the knee. Normal reflexes include lower leg extension. Check reflexes at the ankle, triceps, and brachioradialis as well.
Wait, I should go back. Come.
Okay, ngayon naman, I will test your sensory and sabihin mo lang sa akin if you have or if you feel sensation sa right side or sa left side, and at the same time, kapag soft siya or hard, okay?
Okay po, Doc.
So, close your eyes. Let's start.
Right soft.
Good.
Left soft.
Good.
Right soft.
Good.
Left soft.
Good.
Right hard.
Good.
Left hard.
Good.
Right hard.
Good.
Left hard.
Very good. Okay, open your eyes. So, ngayon naman, tell me if you feel any vibration, okay?
Okay po.
So, close your eyes ulit. So, using this tuning fork, pinch the prong and put it in the knuckles of the patient.
Yes po. Yes po.
Or any bony prominence.
Yes po. Yes po.
Okay, open your eyes. So ngayon, sabihin mo nga sa akin kung yung sensation at saka yung vibration na na-feel mo kanina, if mas sensitive sa right side or left side, or equal ba siya, okay? So sa sensation,
Equal po.
how about sa vibration?
Equal din po.
Okay, very good. To check for lumbar test, instruct the patient to stand feet together, then arms extended. Initially, you will observe his or her posture. After which, let her close her eyes. Close your eyes. Then check if there are changes on her balance as well. Now, you can push her gently and check if she can maintain her balance. Okay? Thank you.
Oh, hey! I didn't see you there. Have you seen their futures? Because you know, I really learned a lot from their experiences. And I can't wait to use this for my future patients. Are you excited? Because I'm excited! Let's go!
Para meron tayong space sa likod. Ating sulitin ang hamog, magsisilbi at taklo.